Welcome to the STARS program, seniors taking active roles in society. And now, here's your host, ANITA FINLEY.
We have a superb medical practitioner here today. It's really important that you know what happens when you go on the radio. Here we have a physician that just came from the hospital doing something wonderful to help someone who just had a stroke. But it's a Dr. Nils Mueller-Kronast, and he's an interventional neurologist at the regional Neuroscience. I'm going to start this again. At the Regional Neuroscience Delray Medical Center, he is the director. So just to get everybody straight, Dr. Kronast, tell us what a interventional neurologist is.
So thank you for having me on. Good morning. An interventional neurologist is basically a brain plumber. It's somebody that goes in and deals with problems of the blood vessels in the brain, either blockages, acute blockages, meaning a blood clot that goes up that causes a stroke, or irregularities or outpouchings of the blood vessels, meaning aneurysms or other problems. So we basically deal with anything that has to do with blood vessels in the brain. Okay. And we come from a background of neurology, so we have training in neurology and stroke, and so that's what we bring to the table, not just the catheter skills, but also the cognitive training.
And you said that, of course, from the time you're young, you're not that young, but you're not in your 20s, but you're young enough to know that at one point there wasn't much that a neurologist could do Correct. To help someone like you do. So Correct. Can you give us a little bit of a background and where it's come to now?
Absolutely. So when I basically was going through medical school and thinking about which training I would go into, the clot-busting agent just became approved in 1996. And since then, it's been a slow process of getting it adopted now. Fortunately, everybody sort of buys into it. It took the ER community, for instance, almost 15 years to believe that truly works. Even though it's a very effective treatment, the so-called number needed to treat is 7, meaning of every 7 patients that you treat, one has a near normal outcome. So it's a pretty powerful treatment. And the problem with it was I have a very rigid time window. So after 3, and now we've extended it to 4.5 hours. After 4.5 hours, we see no benefit. And it doesn't really work for very severe strokes. And so it's somewhat of a niche treatment. When you wake up with your stroke, you couldn't be treated. And what we've always been looking for is a technology that allows us to treat based on the surviving brain tissue. We call that penumbra, the tissue that's still alive when the clot is in place, because there's always a little bit of a cord, or almost always a little bit of a cord infarct damage that can't be reversed, but there's a large territory that we can still save if we take the clot out. And out of all the procedures that I do, stroke is the most urgent one. We try to get our patients onto the table in under 45, better under 30 minutes if we can really do that. So it's a very tall order to get that logistically done. But that's been around since about 2012. We started first in 2004, but it didn't really work well. But since 2012, we have so-called stent retrievers, and it's a fantastically effective treatment. The number needed to treat is as low as 2.5. So, I mean, of every 3 patients, basically, one has a significantly improved outcome. And that's dramatic. It's one of the best treatment effects in medicine.
So how does one know they're having this stroke? Because they got to get to you fast.
Exactly, and actually fast is the most important thing that you have to remember, because face, arm, speech equals time. So we teach the community this acronym that when you have sudden onset of facial drooping that you see in a loved one, because patients often don't recognize it, sudden arm weakness that wasn't there before, it has to be one side, because one-sided deficits really indicate that you have a stroke on the other side in your brain. Speech problems, sudden slurring or garbled speech, not being able to speak, then time is of the essence and you have to come to the emergency room. Don't drive in, call 911, because we can get you into the emergency room faster if you come with EMS. And we get a pre-warning now, which is the thing that we're doing uniquely here in Florida. We actually activate our teams based on the severity of the stroke. We have a scale called the RACE scale. And based on the severity of the scale, we race into the hospital to meet you even before you hit the door. So that's really how we get these numbers down as low as we are right now.
Wow, this is great. I'm so glad you're here on the show. Let me tell everybody who you are. You are actually the Regional Neuroscience Director at Delray Medical Center, Dr. Nils Mueller-Kronast, and it's called Interventional Neurology. So I guess my other question is, let's just back up a little bit. And I know that you are foreign born.
Correct.
And I get the feeling somewhere, is it Scandinavia?
No, I'm German.
German. Okay. Well, because
Yeah.
And so you decided when you were a little boy. I like to ask doctors. So what was this? Were you playing with some sort of mechanisms and you decided to be a doctor? Or
To be very truthful, I'm probably not very good at math. My brother's an engineer and he designs airplanes and complicated stuff, and I just wasn't as good, so I just became a doctor.
Oh, but you still needed math to be able to do something, but
That's
science interested you.
Yes, I have a very scientific mind, and I try to do things that are so-called evidence-based, so we want to prove it. I'm very interested in the research aspect of it. So medicine has been a very satisfying field because you can do clinical interaction and you can mix that with the research, and you have technology that you work with very intimately. So I think it's a nice mix. I've always enjoyed it.
So why a neurologist?
I started off being interested in brain trauma, and did a research project where I actually got to fly on a helicopter in Germany doing trauma research, and from there it segued into neuroscience, neurocritical care, and stroke basically is a large portion of neurocritical care. So I came here, did first a brief rotation for just a month at Johns Hopkins, got interested, and then decided to come here to the United States for training, and did my training at Jackson.
Oh, okay, Jackson's wonderful. And then, of course, you wound up here in Delray. Aren't we lucky? That's super. And it's funny, as a gerontologist, I've been very involved with people with strokes, and I see some people who give up. And then I see other people that take advantage of every possible, possible way to get better, whether it's swimming and whether it's doing things for their brain, because we all know, now we know, but we didn't know before, that we have this thing called plasticity, that even though one little piece of the brain isn't working, the other brain cells can make up for it. So in the time that I've been doing this, 25 years, I have seen a great movement with people with strokes. And it used to be, if after 2 years, give up. No, I know people 10 years later are able. So why don't you talk to that?
So what we have to recognize is that ultimately the clinical deficit after stroke is a function of the amount of brain tissue that's lost. So we know that if you have a core infarct of stroke more than 50 cubic centimeters, that's about the size of a chicken egg or something, then your chance of having a good functional outcome is reduced, just because the stroke is bigger, less tissue is available to take up. If we can do these treatments very early and rapidly, we reduce the core infarcts, and patients either go home or just require minimal rehab. Once the core infarct is done and the tissue is irreversibly damaged, unfortunately we don't grow new nerve cells. From basically the embryonal times, it's a downhill course with our nerve cells. Then we have to rely on other cells that need to sprout new connections, and that does work, but it's unfortunately incomplete. Patients do retain residual deficits, and for instance, for complicated cognitive issues like speech, the recovery, like you said, is a number of years, but it tends to get much slower. Like after about 2 years, speech recovery tends to get much more, the improvement gets much less noticeable and much more protracted than compared to in the first 3 months.
But I know that there's always things, we look at 3M now when we're building new body parts, and the brain, it's funny, for so long, from the very time that I started working in this field, the brain was not thought. It was always the heart, it was cancer, it was something else. Seems like all of a sudden now we have a revolution about the brain. The brain controls everything. So let's get the brain working, right?
Right. There's exciting trials going on, for instance, with stem cells. But the problem is that you do have to be cautious to look, especially when you're doing it not inside a rigorously controlled research trial, but when you're paying for something, then you have to be really, really critical, because the people who make you pay for something and have a gain, they're often not motivated to really critically look at, does this really work, or is it just a placebo effect? And I've had a number of victims being preyed on by so-called snake oil salesmen that came in and said, oh, I can promise you recovery. And in the end, they just had their money taken that they really needed for other things like physical therapy and their medications. And they were left still with the same deficits and just frustrated. So I want to encourage the patients to really go to their neurologist and discuss those treatments in detail, because there are some that have good evidence behind them, but we really need to be very, very cautious, because there's a lot of pressure. People are very desperate, and they tend to go to solutions that are not necessarily proven. And some of the things are very straightforward. I mean, the key issue is it all centers down on prevention. You don't want to have a stroke. And the nice thing is when you have, when you follow these preventive strategies, you actually affect not just stroke, but you reduce your risk of heart attacks, you reduce your risk of Alzheimer's. And it's a couple basic things. You have to basically eat like somebody that lives on a mountain in Sicily.
You do. You're so nice and thin. Do you exercise a lot?
Oh, no, whenever I get time to it, but not enough, obviously.
But you have a diet I can see
Yes.
of probably beans and seeds.
No, I try to follow what's called the Mediterranean diet, or the South Beach diet. Basically, I try to stay away from very saturated fats, red meat, things like that. Eat a lot of fish. If you eat fish twice a week, your risk of heart attack and stroke goes down. If you eat a lot of vegetables and greens, your longevity goes up. So I think it's a benefit all around, and you feel healthier. If you exercising 3 times a week for half an hour is as effective as taking an aspirin.
Oh, okay, that's very interesting. It's funny that I should have you sitting here because, I have never been ill with anything, and every time I go to the doctor, my blood pressure goes up, but it has been up, and I don't pay attention to it. And finally, one of my doctors said, listen, you have got to go find out, and you better start taking blood pressure pills, because we don't want you to have a stroke or to have a heart attack. And so I was convinced, and I went ahead, and it is amazing how my blood pressure came down, but I eat very carefully, and I'm eating much better, as a matter of fact. So having you here thinking, oh, he's talking about stroke, that's what they were all worried about, having a stroke, right? I mean, I never thought about it.
Well, stroke is one disease process that we were worried about that's directly associated with hypertension. Half of the strokes could be prevented if patients were better at controlling their blood pressure. So it's really a very powerful intervention, and sometimes it's as simple as exercising and switching to a low salt diet. Change out the salt, go to using a lot of spices to get your food to the way you like to eat it, and that really dramatically reduces your chance of having high blood pressure.
Oh, turmeric is my friend.
Yes, absolutely.
That's right. You're so right. So you were made to be here on the show today, because I don't usually share this with people, but it just, and the doctors I was talking to, they all are on blood pressure medication. My dentist, I said, I didn't realize everybody seems to be on blood pressure medication, and even though they're exercising and doing other things, sometimes people are more prone to high blood, and as you age, right?
Yes, as you age, your blood vessels get a little bit stiffer, and you're more prone to develop high blood pressure. And we used to, like in 30, 40 years ago, people used to say, oh, it's your 100 plus age is your acceptable blood pressure. And it's absolutely not true. We know now that there's a linear correlation between your risk of stroke. For every 10 millimeters mercury you go up, your stroke risk goes up by 2.2. So it's quite significant. So you should have your blood pressure less than 130 at all times for the systolic value, and 80 or 85, probably 80 for the diastolic value. And,
but if it's lower, the lower
if it's lower
than
is
80
better.
is
The
better.
lower is better. I mean, if you are living at 90, you're basically going to live forever.
Oh, well, you're a fresh spirit here to come, and I have to admire you. Here you had a surgery this morning, and here you are in the show. So you're very dedicated.
I can tell you that getting up in the middle of the night does take longevity away. There's evidence on that. If you're a shift worker,
right?
If you're a shift worker like a nurse, probably takes about a decade away of your life expectancy.
No kidding. I didn't know that. Well, I only do this once on Saturdays.
Right.
I have to get up very early, but I know I've heard about sleeping, and my husband recently passed away, but at 93. But he made sure at 10 o'clock he was going to bed. And sometimes we'd have a dinner party, and he'd come out in his pajamas and say, sorry, you can enjoy yourself, but I'm going to bed. I mean, that was a little eccentric, I think, but he did live to be 93, so maybe there is something to it, right?
Yeah, a lot of it is genetics. I think you can't change that, but you can do what you can do, which is eating healthy, exercising, and yes, getting 7-8 hours of sleep is probably very, very helpful.
And let's talk about stress. We read about that all the time. So are you stressed as a physician?
Probably sometimes. I mean, there are situations where I'm very stressed when cases don't go well, which unfortunately does happen. Stress is something we can't measure well in medicine. There's no good stress screening tool, and therefore, when patients come to me and was this caused by stress, I say, well, probably indirectly, because stress raises your blood pressure, it raises your cortisol, raises all the bad factors in your body, and that is bad for you. But what is the pill? I can't prescribe you to not have stress. You have to find a strategy that works for you, that gets you through the day. And
yoga and all sorts of relaxation methods, right?
Yes, and finding half an hour of time every 2 days for exercise is probably a stress reliever too. That's you time, so that's good.
Yeah, well, you're perfect to be on the show this morning because it's the holiday. The holidays, people are going to overeat. They're going to be overstressed, and we need to not do that.
Well, hopefully they're not stressed. Maybe when they have
maybe
family
having
around.
fun, right? Let's go back to some of the neurological factors in other diseases. Let's talk about ALS.
Mm-hmm.
Now, for a long time, and I had a friend that passed away from ALS, and I didn't think there was any hope for people with ALS. So it seems like people are finding that they're living longer, and how is that happening?
So ALS is not my area of specialty. As I said, I'm a brain plumber. So if you came to me asking for treatment for ALS, I've actually referred you to one of my partners because they're more versed in that. But overall, I think just with the secondary treatment strategies like BiPAP ventilation, other things, we can make ALS patients stay in their homes longer and have less secondary complications. I'm not necessarily familiar with a treatment that truly reverses the course of the disease. Unfortunately, I don't think that that exists. There are some medications that maybe prolong your life expectancy a little bit. They're exceedingly expensive, but overall, to my knowledge, there hasn't been a major breakthrough that really reverses the disease, like, for instance, we've had with HIV, where we've completely reversed the course of the disease.
Yeah, that has really been wonderful, hasn't it? So we actually have someone on Facebook named, well, I know her, Sally Chester, and she's watching, and I know that her husband certainly suffered from, I don't remember what it was. I don't know if it was a stroke, but I know he wound up in a wheelchair, and they're a very he and she are very big community-spirited people, so I'm glad that she's listening. I wanted to move on more with, let's go to MS, and I know I'm picking your brain, thank you, because that's another neurological problem. It seems like, as I said before, the brain has now become in the forefront of so many things. When you think about Alzheimer's, I mean, that's the biggest worry that, I mean, it used to be stroke, but now people all worry about Alzheimer's.
Well, I think Alzheimer's is a big worry, as we have actually made progress on the front of vascular disease, and people actually now live into their 80s and 90s. I think the average age right now down here in Boca Raton is 87 years for a female. So as you enter that age range, it is just much more likely that you're going to develop the pathology of Alzheimer's. I believe I've read that if you take 180-year-olds and you look at their brain pathology under a microscope, 50 of them will have some form of Alzheimer's findings on the microscope, even though they don't have the disease. So it's a very common, very prevalent disease, and you really have to sort of figure out how to deal with this avalanche of cost and how to care for these patients. So we really haven't figured that out, to be very truthful.
Well, we are featuring in our January issue a book, and it is talking about exercise. Really exercising, and if you exercise a lot, they believe that you will not have a lot of these diseases. Now, talk to us. I know, and you're not you are a neurologist, but you seem to be so smart about so many things. So what is it that the exercise does that really helps your brain? We always think of our muscles.
So exercise probably lowers your bad cholesterol. There's data on that. When you exercise regularly, you probably also have less tendency to be overweight. Therefore, you have some of the factors that come along with being overweight, like the metabolic syndrome, being pre-diabetic. All those factors are reduced, and it does lead to improvement, not just in stroke and heart disease, but also actually leads to improvement in Alzheimer's disease. So does, by the way, sleep hygiene. There's some evidence that if you sleep regularly with you prevent or you have a lesser chance of developing Alzheimer's disease. And people think it has to do with some of the cleaning between the cells. When you sleep, all the debris basically gets cleared out, and for some reason that seems to prevent some of the damage from Alzheimer's disease. Now, all those things are somewhat speculative, but it's not actually hard to sleep regularly and exercise and eat well, and so I think everybody should pursue that if they can, and that's the most powerful intervention of all. It's better than being treated for a stroke or for a heart attack or anything after the fact.
We should all watch cats.
Yes.
Cats sleep a lot. They don't eat a lot. Usually they have their little food, right? And they, as you're talking, I think, okay, well, so what is the animal that we can look at? And even more so than dogs, I think cats have a secret. I don't know if you have a cat. I don't, but I'm going to talk about sleeping. This is funny. We always, we produce it. You've seen our magazine, Boomer Times, because that's where we had that great thing that, I don't know, did you write that? That was great. We had that in our issue. It was a wonderful, let's see, here it was. And I loved that article. It was Delray Medical achieves prestigious thrombectomy capable stroke center certification by the Joint Commission. I was so impressed with that. Was that something that you wrote? Or that
I was a participant in writing this, and we were very proud of this, of being the first in Palm Beach that has this designation, being the first certified stroke center overall in Palm Beach. And I think what it just means is that we're moving on from just providing thrombectomy care, which there are now 5 hospitals in Palm Beach that can do that, but what we're realizing is that the care is not equal. We looked at the data across the 3 counties in Florida, and there was quite a significant disparity in how many patients are treated with this technology. That goes from 3% to 20%. So we treat very large amounts of the patients that come in with strokes, and some other hospitals are much more selective and much more conservative, and I think patients are not being given the chance to recover. A lot of hospitals treat a lot later, and every minute you lose about 2 million nerve cells, so we are very proud that, for instance, the first quarter of 18, which is the last number I have, our median door to puncture time was 42 minutes. That means when you come to the door, 42 minutes later we've started the treatment with this clot-busting agent, and patients do much, much better. That's the difference between going into rehab and going home. So that's dramatic.
So how is this this chemical that you're putting, is this done intravenously?
It's not a chemical. So it's a combination treatment. The traditional treatment is the clot-busting, which is a medication called alteplase or TPA.
Yeah.
There's actually a new one that's being trialed out. It's a version of it called tenecteplase. But our treatment is independent of chemicals. It's a mechanical treatment. We actually basically take a rolled up chain link fence, put it up behind the clot, and then we pull out the clot. And we can do that in somebody who's on Coumadin or on blood thinners. We can do it when people wake up with a stroke and we don't know when it happened. We can even do it when there's already some damage, but there's a large penumbra still present. So it really has opened up our treatment spectrum dramatically.
So also, how about when someone's having, you have to go into their brain? I mean,
yes, we go from the groin, we do a puncture, and very quickly.
Oh, so interventional, right, that's
exactly.
the interventional.
It's like a heart catheterization. We basically go into the brain now. We're doing a brain catheterization.
That's right, so you're an interventional neurologist, and I have so many friends who are interventional radiologists, and so you're doing, so this is the exciting part about this. So you've really grown in your own profession, haven't you, in the sense that you were not a neurologist, but now you're, were you always in the interventional radiology? Was that something additional that
So basically when I trained, this training pathway was just being opened up to neurologists. I can't exactly tell you, but I was probably within the first 10 people trained in the nation in this field with a background of neurology, and it's grown exponentially since. Right now we are the largest group of providers. Most people trained in this field are neurologists now, just because it makes sense. The biggest treatment group is stroke, so you have to have a very firm knowledge of stroke to be able to be successful and be good in this treatment. And obviously it's beyond that. We treat brain aneurysms, we treat vascular malformations of the brain, carotid disease, blockages in the brain, anything that has to do with the brain blood vessels we treat, but from a background of having this neurology training, critical care training. So we feel that gives you the best perspective on how to put it all together, and sometimes the right treatment is not to treat, and that's hard. We're not just plumbers, we're also thinkers. So it's
I love it. This is great. So let me just tell everybody, Dr. Nils Mueller-Kronast, who is an interventional neurologist. He is the Regional Neuroscience Director at Delray Medical Center. And I would like to have your cell phone.
Right.
I'm kidding.
We actually know the nice thing we have is we have something that's called the Advanced Neuroscience Network, which is a collaboration between all the hospitals that I oversee. And every hospital that we have in the Tri-County area that's part of this Advanced Neuroscience Network. If you see that on the door, you know that you're going to get good quality care, because we're very, very focused on quality improvement of fixing our times, and our times are among the best in the nation. So if you want to have a stroke, if you must have a stroke, if you must have a stroke, in Florida is South Florida is one of the best places to have it, because you have a very good infrastructure.
Well, Dr. Kronast, I will love to have you back again. You are really spectacular. You're so kind to have come here under these circumstances this morning. Thank you, and I
Thanks
hope
for
you have
having me on. I really appreciate it.
fabulous holiday.
And I'm sorry about your husband.
Yeah, well, 2 years. I was married for 43 years of an idyllic marriage, so I'm just living on the all the wonderful memories. That's how it goes, right?
Thank you.
So anyway, I'm certainly very happy that you came,